Hypertension in the young. Today we learn about how to investigate secondary hypertension in the young, a practical stepwise approach. We have said in the young people, you must always think secondary causes. Once the clinical clues or the red flags are identified, the next step is structured, suspicion-driven investigation. The goal is not to order every test, but to investigate intelligently while protecting the patient from complications. So the first step when you get a young patient with markedly elevated blood pressure is to confirm true hypertension. Before pursuing secondary causes, you must exclude pseudo-resistant, correct BP measurement, which we have already covered, home and ABPM where available, and exclude white coat hypertension. This was discussed earlier in the series. Number 2, basic screening test for all young patients with hypertension. Do urinalysis, urea, creatinine and electrolytes, fasting glucose and HbA1c, do a lipid profile and an ECG and an echocardiogram if available. This helps detect early target organ damage. It also assesses other cardiovascular risk factors like dyslipidemia and diabetes, and also helps in assessing the kidney function. Step number 3, screen for common secondary causes. We said the commonest cause is renal. So for renal parenchymal disease, you do urinalysis, you do your UECR and calculate the GFR, do a renal ultrasound and a renal biopsy if indicated. For primary aldosteronism, we said you think of this when a patient has hypokalemia and resistant hypertension. We do aldosterone-renin ratio and can be confirmed with a CT scan. If you suspect renovascular hypertension, you suspect this in abrupt onset, very high BP, resistant hypertension, the creatinine rises after starting your ACEs or ARBs, or the patient has an abdominal bruit, you do a renal Doppler ultrasound confirmed with a CT angiogram or an MRA. Then you also assess for other targeted endocrine causes based on the clinical clues. If you suspect pheochromocytoma, you do plasma or urinary metanephrines. It's confirmed by a CT or an MRI. If you suspect Cushing syndrome, dexamethasone suppression test or 24-hour urinary cortisol. If you suspect thyroid disease, do your thyroid function tests. If you are suspecting coarctation of the aorta, a patient with radio delay, radiofemoral delay, you do an echocardiogram. This is able to confirm coarctation, but you can also do a CT angiogram or an MRI. Coarctation is frequently missed, but it's a potential curable cause in the young. If you suspect obstructive sleep apnea, patients with loud snoring, daytime somnolence, morning headaches, they do sleep studies or what we call polysomnography. The key thing to remember is that you want targeted tests based on your clinical clues, not ordering all the tests at once. And the principle is treat hypertension while investigating the cause, not after. Treat hypertension while investigating the cause, not after. Waiting exposes your patients to stroke, heart failure, kidney injury, and accelerated organ damage. And the practical approach to a young patient with markedly elevated BP: 1, initiate therapy based on the severity. Individualize the drug choice when secondary causes is suspected. Avoid drugs that may interfere with testing where feasible. And you monitor BP closely during the investigations. Order targeted examinations, targeted tests based on your clinical clues. Refer other in resistance or complex cases. Investigations and treatment must run in parallel. Control the pressure, search for the cause, and protect the organs. Remember, secondary hypertension is not a setback. It is an opportunity. With timely evaluation, you get targeted therapy. With targeted therapy, many young patients achieve excellent BP control, reduce medication burden, and in some cases, where the cause is treated, they can stop taking their medications. So which of those investigations have most helped you in uncovering secondary hypertension in the young. Stay tuned for our next episode, where I will discuss the management principles when treating a young patient with elevated blood pressure. Dr. Beatrice Muthui-Mutua, saving lives one heart at a time.